There's been a lot of interest in the role of FLT3 inhibition in patients who have FLT3 mutations, both in frontline therapy, but also in the relapse refractory setting. Since the approval of gilteritinib in particular, this is the first drug that was approved as a targeted therapy for relapsed refractory FLT3 mutated AML. And the drug led to a substantial number of patients achieving clearance of marrow blasts, which is generally a prerequisite for proceeding to transplant after relapse or patients refractory to prior therapy. So about half of patients will have that type of response, and many would want to go on to a transplant as definitive therapy because long-term survival really is seen in the group that bridges to transplant. So we wanted to know what the outcomes were of patients who did follow gilteritinib therapy on the ADMIRAL study, again, the pivotal trial of gilteritinib versus standard salvage chemotherapy amongst patients who went on to transplant. And what we found is that, not surprisingly, patients who went to transplant in remission had superior survivals to those that didn't. And similarly, patients who went back on gilteritinib after transplant appeared to have better survival than those who did not, recognizing that patients who went on maintenance therapy generally are likely to be in better shape after transplant. But we tried to control for that by essentially doing a landmark analysis at the time point where patients would reasonably be considered for maintenance therapy about 2 months after transplant. And when we look at that, the long-term survival is really strongly predicted by did patients go on to transplant? If they did go on to transplant, did they get maintenance? And then lastly, were they in remission to their salvage therapy prior to transplant? If you had all three of those, about 50% of the patients were long-term survivors, which is really quite good in a relapse refractory setting. And so I think this is, essentially the new standard in terms of how to treat patients is to use gilteritinib in that setting. The questions we don't know the answer to, because the ADMIRAL study compared single-agent gilteritinib to salvage chemotherapy, is now that we have an approved drug, you can obviously use it in any way you seem fit as a treating physician. So would combinations be better in that setting? And lastly, would we want to prevent relapse in the first place? So there's been a lot of interest in the role of maintenance therapy in frontline chemotherapy-treated patients. That's the subject of the MORPHO study that was released at EHA this year. I would just caution that that's a very different and generally lower risk population. So we can't necessarily use those data in the relapse refractory setting where relapse after transplant risk is very, very high.